Good afternoon, everyone. Today, we had reached to the final closing ceremony of the online competition, which is organized by Indian Society of Radiographers and Technologists. So on the occasion of 125th anniversary of discovery of X-ray. We had initiated this program 8th November 2020. With this, we are ending today's session with the closing the ceremony of the all the event. So with this, I welcome all the guests and the chief guest of the today's event. With that, I request Mr. Anto Ramesh Delvi, a national coordinator for NCISRT competitions, and also he is the radiology manager of Colombo Asia Hospital, Bangalore. I request Anto sir to welcome the guest and the participant.
Namaste everyone. Thank you, Shashi. Dear colleagues and friends, it is my privilege and honor for this closing ceremony to talk about the event, whatever has happened on this. Actually, Indian Society of Radiographers and Technology, NCISRT 2020, we had an online competitions. Normally, every year we used to have offline meetings, but this time due to this pandemic, we have been forced to engage through online. First, we thought it will be a great difficult task, but with ISRT leadership team and also all the coordinators and the committee people, the regional people, we are able to achieve this. So I thank Shashi, who was holding hands with me for the complete event. So during this welcome note, I heartily welcome our chief guest, Dr. KSHITIJ Mankad, clinical lead for pediatric neuroradiologist, Great Ormond Street Hospital for Children, NH Foundation Trust, UK. Sir, we welcome you, sir. It is a great privilege and honor for being with us. Also, at the same time, we thank our Suresh Malayat, our General Secretary, and also Mr. Selva Kumar, President, ISRT. And the other members of the ISRT, I like to take this opportunity to thank Mr. Sushwan Ban, and also I welcome everyone for this event. And thank you, participants, for taking much time on the last 1.5 2 months. You are with us, engaged with us, and you are intensively participating. And we thank all your professors for engaging with us. And also, we like to thank Professor Panneerselvam sir, Suresh sir, Mohanlal, Partha, and Commander Daniel sir, Yogananda, Taslim Sheikh, Shashi Kumar Shetty, Mahesh, and Abhijit, and all the people who have put heart, core, and soul in this event. Once again, I welcome you all for this program. At the same time, I like to thank Sono Sir, Atomic Energy Regulatory Board Affairs, who also was supporting us for this event. And thank you again. Once again, I like to welcome Dr. Kesh, who's a consultant. Actually, doctor, he has an extensive education and training portfolio, having directed and delivered comprehensive teaching programs across UK, Australia, China, India, and South America. Actually, it is very honor and privilege to have you, sir. And also, Dr. Kesh is also trained in Lean Six Sigma, Master Black Belt, and completed an MBA Essentials program with the London School of Economics. As such, he is passionate about quality and safety in radiology, improvement in the field of radiology, with a strong focus on healthcare economics and organizational behavior. Once again, we welcome you, sir, and I welcome all the participants and also the judges of the complete event, which has been with us for this 1 month. Once again, thank you all and welcome you all to this closing ceremony. And over to you, Shashi.
Thank you, sir. Thank you for the welcome note. With this, I request sir, today's guest speaker to take over the session. Can you share your screen, sir?
Good morning, good afternoon, namaste, ISRT. Particular thanks to Anto for having invited me to participate in this adventure, I would call it, from the International Day of Radiology, where we had run a course down from Sydney as well into the world. But it's amazing to know that Indians are doing so well And I think the impact of this is going to be far reaching. So I was given a completely clean canvas by Anto to essentially talk about anything I could today. And I randomly chose a topic on situational awareness, something I have been thinking about a lot recently through cases, through our practice, and the entire risky business called radiology. And when I say radiology, everyone's included, not just the radiologists and the doctors, it's the radiographers, the nursing team, the sedation team, the anesthetists, the admin staff, anyone who is important in this pathway of risk management. And risk management essentially is error proofing the system, ensuring that things don't go wrong as far as possible. We can't eliminate risk completely, but we can definitely minimize it. And I think situational awareness is something we don't think about, but actually are involved with. It's ingrained in our practice on a pretty regular basis. So take it from a radiologist. I'm not a psychologist, but this is my angle at understanding keywords: perception, vigilance, attention, prediction, projection, reflection, acceptance, creativity, and finally, evolution. And this is how situational awareness would lead to better outcomes for all our patients. But particularly today, we're talking about pediatrics, special to my heart. And I think looking after children at the right time makes the biggest impact to the world that we live in. So here we go. This is going to be a storyboard. But before I get started, let's start with a moment of reflection. What to a radiographer or a technologist is a good diagnostic test? We are in the business of good diagnostic tests, good quality images, lots of fancy sequences, advanced and not so advanced imaging techniques. But fundamentally speaking, in your head, if you can build a cloud and think about what exactly is a good diagnostic test, is it something that looks good? Or is it something that can make money for the organization? Or is it something that I do better on a 3 Tesla compared to a 1.5 or lower strength Tesla scanners? And the answer to most of those questions is probably not. A good diagnostic test is a test that adds confidence to the clinical management of a patient. So we are therefore integrated in that pathway or that patient journey called effective, precise, and accurate patient management. So whatever we deliver with whatever resources we have, because resources are limited. I'm not going to show you examples of 7 Tesla imaging because that's the state of the art. To me, the state of the art is getting the best out of the resources that one has. And using that then to provide confidence to clinicians who are the front runners in terms of detection, diagnosis, and precise treatment, whether it be medical, surgical, or no treatment. And therefore, the final beneficiary of this entire practice is that sick person. Could be a child, could be a very elderly person. I'm going to show you some instances of where radiographers actually made a difference. Because there is a tendency for people to be in the darkness of the console, scanning away, radiologists just expecting a scan to be sent to the system. But I think that needs to change. And this is how we will change it. On working together and being able to communicate effectively what we see at the moment of truth. My first vertical or domain of situational awareness is perception. This is a story of a 12-year-old girl who presented with sudden onset back pain. Sudden onset back pain, warning sign, red flag. You probably are thinking we should do an urgent MRI scan of the spine, and that was done. As a standard sequence of sagittal T2s, there were some sagittal T1s, and then some axials thrown in there. And I'm showing to you the T2 weighted sequences. What ensued from here in this story was the fact that, okay, there is a spine image here, and there is a sudden onset of pain. The diagnosis we're going to make, this is as per the radiologist, a verbal report of epidural collection, and followed by a written report also of an epidural collection. The case is referred to the neurosurgeons. The neurosurgeons are sharpening their tools to take this patient to theater because if this is sudden onset and this is epidural, it needs to be drained, whatever be the cause for it. Comes along a savvy radiographer and says, hold on, I was wondering how you had reported the scan, but actually this is a pediatric patient and we see this not uncommonly. Are you sure this is an epidural collection? Could this be CSF flow artifact? Because you see, it's not exactly sitting on the surface of the cord. The signal of the spinal cord is preserved. And you look at the axial, it tends to shift between sequences. But most importantly, we don't see abnormal blood vessels. We don't see the substance of the cord actually pushed away in any particular direction. This is indeed motion artifact. And people see motion artifact quite commonly in children. Finally, the on-call consultant is called in. A team meeting happens. The final diagnosis is revised to normal spinal and intraspinal appearances. Let's talk about vigilance. This is a story of an 8-month-old girl who presented with seizures. Now, seizures is common as a neurological presentation in unwell children. 20% of any underlying etiology, be it stroke, be it epilepsy, be it a metabolic disorder, would present with seizures. So it's a very non-specific presentation. But we are dealing with a child who is under 1 year of age, 8-month-old girl with seizures. When they present acutely, CT still is the primary imaging modality for emergency imaging. Except that this CT scan is read as a normal report from the local referring hospital. Fine, we do see some prominent spaces in 8-month-olds. It's not a surprise, especially when the head size is a bit big. What's missed out on this is a subtle finding, but this only becomes relevant when this patient then goes on to have an MR scan 3 days later because the seizures are ongoing, the child is encephalopathic. Who is the moment of truth, the interface? The first person to look at that scan on the console was the radiographer, picks up the bilateral subdural collections on all sequences, as you can see out here, and urgently calls in the pediatricians saying, there are bilateral subdural collections. They were or were not present on the CT scan. We're not sure about that. But until proven otherwise, we're talking about safeguarding issues. We're talking about abusive head trauma. This is not the presentation of just epilepsy and seizures, but the context is different. Vigilance can make the context more precise. Look back at the CT scan, there is indeed that finding of what was a small subdural collection building up. Look further, the density of the cerebral hemispheres and the density of the cerebellum are a bit different. This is a subtle call, but it actually shows global cerebral edema at presentation with some preservation of the cerebellum. Abusive head trauma until proven otherwise. And then there is prediction. Think about this 1-year-old boy who was referred for suspected NF1 because he had some skin lesions and family history of neurofibromatosis type 1. The originating hospital sends us these scans for a second opinion because they have been reported out there as multiple white matter dysplastic changes. And then when you look at these scans, you can see why this was referred to as signal abnormality involving the mesial temporal areas. Also looking out to the temporal lobes out there, you see blurring of the gray-white interfaces. In the basal frontal region out there in the orbital gyrus rectus region, you are picking up blurring of the gray-white interfaces. And you are tempted to believe that probably there are multifocal changes in this child. But the context is of neurofibromatosis screening. The age of the child is 1. The sequence we are looking at is flare. White matter maturation appears to be complete on T1 weighted sequences by the age of 1, on T2 weighted sequences by the age of 2, and on flare it takes up to 4 to 5 years to appear complete. We are dealing with an immature but normal for age brain. So in fact, the radiographer in this instance, when I showed this in a meeting, said, why are we even doing a flare at this particular age? Because we are going to pick up a lot of immaturity of the white matter in this particular instance. And I said, that's good. That is called situational awareness. We can't throw the same protocol on everyone. We have to optimize, and therefore we have to customize. Look further. This is about attention, a very important aspect of situational awareness. The radiographer who was scanning the spine for a suspect spinal dysraphism associated with some intraspinal cystic changes out there. You can see there is also some vertebral alignment issues out there, some distortion of the spinal cord, but on the axial, worried about what this finding was. And this is an incidental pickup of a pretty large multilobulated fusiform renal artery aneurysm picked up subsequently on the right diagnostic test and treated by embolization. The attention to detail and the satisfaction of search is not just the realm of the reading radiologist. In fact, in the UK and in the US at the moment, we have a very few people, radiographers, training to be reporting radiographers. And I do hope that someday a radiologist goes back into the scanning room and is able to scan a full patient. Hands up, I am unable to do that. But this is about shared knowledge and shared responsibilities. Detection of a renal artery aneurysm leading to DSA, leading on from there to an effective management of the patient. This could have been missed if we just focused on the spine. Our region of interest is not the part of the body that we have been asked to image. Our region of interest actually is the full patient. Look further. This is one of my cases, in fact, one of my misses. Discrepancies, errors, learning from mistakes, the way you look at it. And that's where the concept of reflection becomes very important. This is a story of a 6-year-old boy who presented with headaches. The mistake was the hospital here had just done some very fast imaging because on the CT it was felt that they had 4 ventricular hydrocephalus, and we were just trying to ensure that there was nothing odd in the brain. So in fact, very quick 1-minute protocol, volume T2s, and some flare sequences. My mistake was accepting that at face value. Looking at the ventricles, I said this is 4 ventricular hydrocephalus. And it seems to be long-standing because we don't have much in the way of CSF seeping out into the brain substance. I looked at that and I reported that as some CSF disturbance along the 4th ventricle. And then I stopped looking and I stopped questioning. Constant interrogation is safe practice, especially where we are working. The patient's headaches were resolved by putting an EVD or an external drain into the ventricles. But the patient did not get better. They continue to have vomiting, recurrent headaches. They were rescanned, and this time with contrast, after the ventricles had been drained. And in this particular instance, what you see is a rather difficult lesion, which is taking the configuration of the ventricle and the aqueduct where it is sitting, more conspicuous on this sequence. What is the difference in this and this? And this difference in conspicuity happened because the savvy radiographer decided to stray away from protocol. The protocol for imaging was a gradient echo 3D-T1. The contrast conspicuity on that is not great. The radiographer decides to kind of extend the scanning into a spin echo with contrast as well, and the conspicuity of this mass was therefore established. A low-grade astrocytoma presenting in this format, and looking back, it's all there, it was always there. Upon reflection, if you're doing fast protocols, make sure you question the scan and the findings to your level best. Here's a story of focal seizures and a story of acceptance. In fact, both of the instances is about reflection and acceptance. Mistakes will happen. We looked at a snapshot of how the world does in terms of discrepancies some years ago. 15% of what any radiologist would report at any given point in time is going to be discrepant in the best practices of the world. Now, 15% is basically 15 out of every 100 you report, and that can be quite sizable. What we did not do was grade the level of severity of these cases. This child who had seizures and EEG pointing towards the left temporal region, the information is quite limited on these request forms. But as radiographers and as radiologists, we need to make more sense of what's been given. These are focal seizures. This scan was interpreted and read as an arachnoid cyst. It's not a bad call. Whatever is happening has been there for a long time. There probably is some cystic arachnoid loculation. You can see that the brain, the skull actually is expanded out there. Probably there is some scalloping of the inner vault of the skull as well compared to the other side. But the child is not going to improve if I'm going to drain that arachnoid cyst. There is some distortion of the brain tissues. But when you look closer, you're going to pick up some gliotic changes in the brain substance. This was in fact a report that was then changed to scarring of the brain, which better explained the seizures than just the arachnoid loculation that accompanied it. Things evolve, and things evolve because we constantly question our own findings and conclusions and inferences. Which brings us to a very key theme in situational awareness development, one of standardization and optimization. As radiographers and radiologists, we need to think like a clinician, predict what the report should answer in terms of the question that's being asked, and therefore plan accordingly. And when we talk about standardization, optimization, and customization, we have to remember I've used the term moment of truth a few times before. And now I'm going to explain to you what the moment of truth actually means to a radiographer. When you're informed by the booking staff that your next patient has arrived and you're supposed to scan them, you actually walk up to the patient or the parent or the family or whoever you're going to scan. You talk to them, you do a safety check, and at that moment, for the patients, so-called the clients of the hospital, you are the interface. You're the first person from the department of scanning that they're actually seeing. And the perception in the masses is that we are all doctors. We are all medics. Many a times, I'm happy and I have been called radiography. People don't understand radiologists as doctors. Anyone in the hospital who deals with the patient to them is at the pedestal of a clinician. And you are going to see the patient. You are going to see the findings on the patient. As in this particular case, there is a rash on the skin. Seems to be quite well demarcated, involving one side. And when you have a story to go with that of seizures with the Port wine stain, you are not going to do just a routine scan. You're going to think hard about what is the combination of seizures and port wine stain. And you will get that knowledge not just by reading books, but I want you all to come out and attend clinical meetings between clinicians, radiologists. They are happening in all hospitals now. Make sure you are in attendance. Because only when you get the combination right, you know you're dealing with an exclusion for Sturge-Weber syndrome. And in this context, you're going to do an epilepsy protocol scan. In this context, you're going to give contrast because you need to pick up the PL angioma on the brain, which cannot be seen in any other sequence but a contrast. And if your hospital does not have a policy of administering contrast under the age of 1, you're going to work towards ensuring there is one in place. Otherwise, your imaging is incomplete. And in this particular instance, what you see is a malformation of brain development. This is polymicrogyria in this particular case. Look further, you do a susceptibility weighted image, you pick up calcification of the gyri. You give some contrast, not picking up the best looking PL angioma, but you know, because you're a savvy radiographer in 2020 AD, that flare with contrast probably will increase the conspicuity of lesions that do not easily get picked up on the T1 with contrast. So you do a flare pre and a flare post contrast, and you pick up and demonstrate that PL angioma, confirming the diagnosis of Sturge-Weber syndrome with associated extensive polymicrogyria in this context. And remember, you live with whatever we have. Resources do not dictate quality always. A well-optimized 1.5 is better than a badly optimized 3T. And I use this example because I think I can see that lesion better on a 1.5T compared to a 3 Tesla. In the context of epilepsy, of course. Next important step in situational awareness is projection. Be alert to the revisions to the diagnostic criteria. This year of the pandemic, as I call it, has seen some very important papers being published. And you have to go and find this as homework. Read it, summarize it, present it to your audiences, and stick it on the wall, because our protocols should be aligned with these guidelines which have come up and are being advertised and used the worldwide. Why is it important to be aware of revisions to diagnostic criteria and match the radiology to that? Here's an example. This is multiple sclerosis. The whole idea of revising the multiple sclerosis guidelines now in the last 20 years on 3 or 4 occasions is the fact that earlier detection, earlier diagnosis, and earlier management leads to better outcomes in most of these cases, thus reducing the disability of the patient over time and altering the natural course of disease. Based on the 2017 revisions to the McDonald's criteria, now 3 years old, we started using 3D FLAIR for all our multiple sclerosis patients. Of course, some centers still do the double inversion recovery, but this is good enough. And why did we change practice? We changed practice because at this point in time, if you pick up a lesion in the periventricular white matter, or in the deep white matter, or in the cortical region out here, it would contribute towards the diagnostic confirmation for multiple sclerosis. And you would not be able to pick up these findings if we stayed with the original conventional protocol. Grow with the times. And when we talk about growing with the times, we have to talk a little bit about response assessment in brain tumors. We see brain tumors as an incidental finding. There's a lot of focus on diagnosis, but I think the key point, the real difference one makes as a radiographer and a radiologist, is what we do in terms of assessing response. It's the relapse that kills the child. It's not the presentation, by and large. And here, for eons, for many years, people believed that if you suspected METs in the context of medulloblastoma, CSF examination, get some sample of the fluid around the brain and spine and confirm the diagnosis. It's now been proven that CSF analysis is not the gold standard. Look at the difference in the pickup rate for metastasis. So MRI, but how do you optimize your MRI in these embryonal tumors like medulloblastomas, ATRTs, ETMRs, even the low grades, for instance? It's not just good enough always to do a T1 with contrast. And these patients were CSF negative, remember. So MR is the new gold standard. But one sequence does not catch it all. You've got your T1 with contrast, which picks up the leptomeningeal disease there. You've got the diffusion in this particular context, which picks up these nodules around the ventricles better. And then further on, you start kind of looking at FLAIR with contrast, picking up more extensive leptomeningeal dissemination. And whilst doing all this, it's important to remember that we have to reduce the scan time. Do it faster, do it more effectively, and get better results. Here's an example. This is a longer acquisition, but this is no gap. You give a 25% gap, you miss the metastasis. You miss this metastasis, they're going to come back in a few months' time or even few weeks with larger, untreatable lesions. You pick this up, you can go in there with your surgeons, get it out. Good outcomes. Look at this example of a 2-year-old with medulloblastoma, and these scans are 2 months apart. This was initially missed. Look at this 2 months later, extensive leptomeningeal dissemination. But if you look at the diffusion, you don't really pick up much. So when we talk about complementary imaging techniques, I am still talking about conventional sequences. I have not shown to you so far anything which is remotely advanced imaging the way I see it. 4 months apart, things become more and more blob-like and become easier to see on all the other sequences. But the trajectory of growth, this was initially missed, comes back grown. Of course, we are going to miss because somewhere things are starting and they're not going to be picked up. But then there is a rule for repeat surveillance at shorter intervals. Who suggests that? You expect the radiologists on their report to suggest it, that's fine. But at the moment of truth, if you pick up something like that, you are going to pick up the phone and let your radiologists know as well. They will only be thankful. Thinking about spinal imaging, this case here, going back to where we started about perceptions, this was reported as thoracic METs. This was T1 and T1 post-contrast, and people felt that whatever was being seen is also enhancing. But actually, 3 weeks down the line, this is the power of quickly repeating imaging. I don't like recalling patients, but sometimes they have to be recalled when the quality is poor in the first instance. 3 weeks later, no treatment and nothing seen. But you can see this is a much more optimized spinal imaging protocol. Talking about spinal imaging and optimization, there is a significant role. If you're thinking about sagittal T2 and not sure about the findings, there is a role for CIS or Fiesta, depending on what scanners you use. and you will be able to pick up subtle lesions which impact management significantly. But remember, my aim is not to add sequences to your list. What I want you to work on is aligning to guidelines and protocols, but improving on them, but making it shorter and more effective for children. There is a clash between standardization and customization. And this is where situational awareness tells us that we need to also evolve with our times. This is a true story of these two children, conjoined at birth, connected in the head area. And it's not that simple. First of all, to scan them, you need two anesthetic teams. You need to block off an entire 4 hours of your scanner time because you're going to sedate or anesthetize. You have to consider contrast. You have to inject both of them separately. You have to plan your scan because you're essentially trying to answer the question whether these brains are connected and how much sharing is happening between the two twins even before the surgeons can think about separating them safely. And if you look at this combination of MRI sequences and CT with contrast, you will quickly realize that these kids are actually sharing a lot of their venous drainage. They are sharing some of their arterial supply because this brain belongs to kid number 2, but they are being supplied by the posterior cerebral arteries from 1. And there are areas where you're going to find it very difficult or impossible to separate the two brains. This is a case from 2 years ago in our hospital where creativity was called in, and we just couldn't live with what was standard protocol. We had to improvise on the go. Improvisation happens not just when you get conjoined twins, even in simple scenarios like this one, where you have a 2-day-old son and a 40-year-old father. And if I were to ask you, label the T1 and the T2 weighted sequences here, you probably might get confused because people call that a T2 weighted sequence because, everything looks bright and nice. The reality is that this is a T1 weighted sequence. In the context of a child who is born, this is indeed a T2 weighted sequence, but look how the story evolves over time. This is maturation of myelin. In the 2-day-old, you've got white matter of the brain that appears dark, appears quite bright on these T2 weighted sequences because of the high water content in the brain. Over time, the water dries out, the lipid or the fat content of myelin proportionately goes up. T1 shortening happens. This is maturation of the brain in time. And if you put it together, you can actually know how to make your sequences optimized for the 2-day-old son and the 40-year-old father. I thank you for your attention. I hope that was useful. But remember that situational awareness in pediatric neuroimaging is indeed the foundation to good decision making, and we do have a collective, shared responsibility in that process. Thank you. Stay in touch. Merry Christmas and a Happy New Year. Hope 2021 is a beautiful year for all of us. Warm wishes from London to you and your families.
Thank you very much, sir. It's a wonderful presentation.
Thank you so much, sir. It was a wonderful presentation. I say that you had explained in a way how important the sequence, maybe the situational, the technique by the technologist, maybe the radiologist. That's what the wonderful presentation, sir. Thank you so much. Any questions from the panel? The member? We have one question from the audience, sir. This
Sure.
is regarding what kind of sequence you suggest for trauma patient considering for a quick scan?
You can do a full brain scan in 6 minutes, even in a child. And I would definitely do the standard axial T2. I would follow it up next with a susceptibility weighted sequence of any nature that you can use. You can have, I would try to do an SWI. If you have a gradient echo, that's fine. And then I would move to a diffusion and a T1. That can be accomplished in 6 minutes. But you have to optimize your axial T2. You shouldn't spend more than 2 minutes doing it.
Okay. I think
also important to remember is the sequence in which you choose your images, because if you're answering the question of how much brain injury there is, I think I would start with a diffusion and susceptibility. If you're trying to answer the question of acute stroke, I would still start with a diffusion. But if I'm trying to answer why is this child having epilepsy, I would start with the volume T1 and flare and then go to the other sequences.
Okay. There is one more question, sir, maybe which is relevant to in our country. There was a question about there are for the any trauma cases, most of the places they've done a CT. So it is CT or MR, which you modality you.
Oh, absolutely CT, I think, first for trauma. And I know trauma is quite common in many centers across the world.
Yes.
Absolutely CT. It's not just quick, actually, it's got added value in terms of looking at what's happening to the brain, making urgent neurosurgical decisions, picking up fractures. It has definitely got better resolution for bone. So CT first, and then we think about MR next.
Yes.
Even in children.
Even in children, yeah. So it is utilized in worldwide, as you say. CT is
I would like to also add to that. In fact, I probably should have shown a scan, but the concept of ALARA and keeping it as low as reasonably possible and achievable in terms of radiation protection should be taken with a pinch of salt, because sometimes just putting the dose of your MA low actually might make the scan non-diagnosable. So it is a balance of risks. So make sure you optimize it well, give the adequate MAs and the KVs for good quality CT scans. The scanners these days are optimized to reduce the radiation, so don't worry too much about it. At that point in time, you have to answer the clinical question. So don't, put a CT with a 50 MA, make sure you have 150, 200, whatever your protocol is, because you need a diagnostic study to answer the question.
Okay. I think that is what the two questions I received from this thing. One more question from the student perspective side. What should be the basic rule that we should follow suffering from the CSF meningitis or any vertebral degeneration grade 2?
CSF meningitis and vertebral degeneration.
Grade 2.
Possibly two different questions. I will answer to them separately. I think if the question is about CSF meningitis as in neuroinfection in the brain, now the teaching has traditionally been that you don't need to do any form of neuroimaging before a lumbar puncture can be done. And I think it's very difficult to get out of the situation of not doing any form of imaging. I would do a simple routine scan, give some contrast, and get done with. As far as vertebral degeneration is concerned, I think there should still be a T1 and a T2 and a stir. And if you're not sure, then go through with it and an axial as well. But I think this is good enough to answer the question. I don't give contrast to the vertebral degeneration scenarios. I think that's a waste of contrast, and it's too expensive and unsafe.
Okay.
Because I know in India, patients still have to go and buy their own contrast vials in many centers. And if it's not adding any value, then I don't think it should be done.
Okay. With this, I think all the questions you had answered. With this, I think, thank you, sir, for your wonderful session. And I knew that it is a very valuable time for me, for you, since it is, you said, is a morning, maybe, uh, even though Sunday, definitely we
No,
were
it's
talking.
okay. This is good. It's always good to connect with Anto, anyways. So credit is all his to call me over.
Yes, thank you so much for accepting our invitation and
Thank you
being
very
a
much,
part
sir.
of our program.
Suresh,
With this, we have moving forward for the program. I see that our General Secretary Suresh Malyat sir also uh, entered to the meeting. Suresh Malyat sir, welcome you. Okay. With this, I think before we going to the closing remark, I will present a presentation regarding on the winners announcement, as well as we had a continuous 6 week events. I'll just have a short summarized program, which is I going to show it in the presentation. I think everyone knew well aware of that Indian Society of Radiographer and Technologists, which is initiated on November 8th. Many in online competitions. There was 946 participants, include all the three events. Around 105 colleges registered for the quiz competition itself, and 48 oral presentation registered for the staff, maybe teaching and non-teaching, radiographer, technologist, lecturer, assistant professor. They're all be a part of the oral presentation. And we had received 118 posters with the topic of radiography and radiation protection, computer tomography, and MRI. I think all of you seen that on November 8th, we inaugurated with the one of the renewed radiotherapist, Dr. Amrut Kadam. Is the Deputy Registrar of Rajiv Gandhi University of Health Science, and also by